major themes. And so we're going back to them about this, but people are joining in. In addition, we have funded from NIHR a translational research collaboration across all the main centres in rare diseases to do deep phenotyping in rare diseases. So there's a lot of work going on there. So actually, I think if you look at where the recruiting sites are for rare diseases all around the country, I think you can see that the rare diseases will fly, cancer will fly, and we will get there. This is a very complex project. It doesn't keep me awake at night, but I do sometimes wonder how we will get it all to work. If you look, and the logistics people talk about how we have to have a buffer of extra samples for the line going into the sequencing and everything, it's very, very complicated. Finally, I just wanted to mention two other projects which are of interest from the public health and genomics perspectives. One is UK Biobank, where 500,000 people between 40 and 69 were recruited over 4 years from across the whole of the UK to join in. We access their NHS data, they fill in questionnaires every year and have physical examinations in great depth. Indeed, we're doing MRI scans of 100,000 of them for dementia research, and the MRC and ourselves have funded a genome scan of all 500,000 of SNPs. So that is also going on, and we can, if we need to, link up the data. And clearly, if we're doing all of this, and there are lots of samples, the classic way of looking after samples is, in fact, putting them in academic departments, but that's very costly if it's in the centre of London or somewhere else, and that doesn't work as well as it should. So we have funded, and it's now completed, a roboticised -70 biosample centre to store samples not only from these different projects, but from all academic studies that have been funded, so that they can be stored safely, actually processed on batch, and retrieved. Because if you go to most academic centres, they do their study and they store them. You then want to do more work, and the retrieval is very expensive and very difficult. But with our robotic storage, which is an absolute copy of the UK Biobank one in the north of England, we have complete simple retrieval and very, very cost effective. So actually, the major London hospitals and medical schools are already talking about how they're going to empty out all their freezers and send the stuff to there, because it'll be much cheaper and better for them. I've been through quite a lot of different things, but we can only make progress if we take the public with us. We can only do the genome projects if we take the public with us. And on antimicrobial resistance, I think this is terrifically important. So I have, with colleagues, written a book called The Drugs Don't Work, about antimicrobial resistance for the public. And I've also, and it was the most scary talk I've ever done a TED talk, which is up there. It was scary because 4,500 people, you're not allowed notes, the time clock clicks down, and there are certain things, if you're doing a TED talk, you must say, like, this is an exciting idea I want to share. I hope that you've found all of what I've had to say exciting. I did want to share it, but I wanted to share it because only by working together, not just as academics, but with the public, not just in the UK, but with you in Canada and across the globe, will we be able to sort these problems that are immense. Not for nothing have I put in the effort to get antimicrobial resistance on our government's risk register. It needs to happen in every country. This needs to be taken seriously. Or we go back to a pre-antibiotic era, an era where 43% of people died of infection. It's 7% at the moment. Where we died on average at least 20 years earlier, according to WHO data. Where modern cancer treatments would be of no relevance because most of them drop your immunity so you get infections. Where transplants would not be possible. Where routine surgery, the cesarean section I had 19 years ago, the shoulder operation I think I may end up with in the next year or so, would have a high risk of infection. Things that we take for granted would be lost. And they would be lost because we didn't call time on it early enough to get new antibiotics. And that's what I'm doing and what all of you need to help me with. Thank you.
So Dame Sally, thank you very, very much. So as you talk about entering the fifth wave of public health and it being social engagement, I mean, how apropos for you to take the time to come and share your views with BC. And so we really appreciate that. So we've left a good bit of time now for question and answers. And I would ask you, there's microphones. There's my right and a microphone on the left. So please come up. I'm going to ask you to please identify yourself. I'm also going to be handed a iPad here and there, and I'll be taking some questions from Twitter and passing those on to Dame Sally. And maybe as the first person's coming up, I'm just going to sneak in a question I'll get one question of my own here. And what I wanted to ask you is a question on Ebola. And so you mentioned it, and I mean, I think it's kind of top of mind for a lot of people right now in a lot of countries. So the way I want to ask this is for you are a consultant to the UK in terms of the whole Ebola crisis, but you're also a consultant to the World Health Organization. So what do you what's your advice to the WHO, and what's your advice to David Cameron when he calls and asks if he needs to be concerned about Ebola in the UK?
So I'm an advisor to the government, and I'm on the executive board of WHO. So to my Prime Minister and my ministers, I say, we are prepared in our country for if we get patients. We have two beds, standing beds to Category 4 to care for patients. We have plans to go within a few days up to 18 beds, and we can extend more than that if we need to. Meanwhile, we have a public health service, Public Health England, whose kind of bread and butter job is contact tracing and giving advice and making sure we get it right, to pull in the people who might be infected and make sure that everyone is protected from them and that they get the best treatment. So from a country perspective, we're in a good position because we've been working at this since June. But from a perspective globally, which is the WHO and our country perspective, there is a real concern. This is not in control. The doubling time in Liberia is 2 weeks. In Sierra Leone, for which we in the UK have taken a lead responsibility, it's 3 weeks. We have now had over 3,000 deaths, and it's going up day by day, and the local people are scared. They are scared of the disease, they're scared of the people who come to look after them, and they are scared that we are giving it to them. We, as a world, did not sort the social sciences, the anthropology of what was going on early enough, because many of the transmissions are around the rituals to do with death and funeral rites, the handling of bodies and all of that. But you can only change those and stop infection if you understand what's going on and why, and work with the community to help them change them to protect themselves. And we've started on that journey as a globe, late in the day, though it has started. And we're going to have, we've got so many cases, you can't do active contact tracing any longer in West Africa. It's overwhelmed the system. So we're looking at a new way of trying to do passive contact attraction. Can we incentivize people who are ill to come in and be checked? And if it is, as it is more likely to be, malaria or some other disease, treat them for that while not exposing them to people who might have Ebola. And if it's Ebola, getting a speedy diagnosis and giving them the best treatment we can. But there is still a 70% mortality. So this is a real worry for all of us.
So we'll take a question on the right, Diane.
Thanks, Dame Sally, and thanks for your generosity of your time today. It's been great. I want to go back to the beginning of your presentation where you were talking about the culture of health, and it was interesting that you juxtaposed that articulation that we need to move to a culture of health with morbidity and mortality statistics. So the question is, if we really want to promote a culture of health, shouldn't we be moving towards indicators of wellness, not indicators of sickness or disease? And are you doing anything in England about this? Our own First Nations Health Authority here in BC is really working hard to try to develop indicators of wellness.
Interesting you use wellness rather than well-being. I had thought my last report would be public mental health and well-being until I dissected well-being and realised that in that case there wasn't a proper definition, and therefore the measure that people were using in the UK actually doesn't stand up. It's taken bits out of a mental health screening tool, and if you use those and you get a low score, you actually have psychiatric morbidity, and they're saying you have a lack of well-being. So it's a complex area, but there's a very good chapter in that report. I do think wellness is important, and particularly for cultural engagement and everything, but it's like happiness. I think, how do you get hold of it? I have a number of chronic diseases. I've already mentioned my shoulder. Yet I clearly have great well-being. I have great happiness because I'm fulfilled in the ways I wish to be fulfilled. And so I think it becomes very difficult. Our Office of National Statistics, at the request of the Prime Minister when he came in, he said, I want a different measure from GDP, I want a well-being measure, have started some work. They have a big wheel of questions they ask to do with well-being. And some are subjective, but a lot are objective. And I think that approach is quite a good one, where you use lots of parameters and you just get a feel for it. But I think to get more into it, we need more academic rigor, and we ain't got it yet.
Yeah, I would agree. Thanks.
Fiona.
Yeah, first, thanks. That was a fantastic talk and inspiring comments. I'm an infectious disease researcher using genomics and bioinformatics to help develop more sustainable approaches for infectious disease control. But one of my greatest challenges is actually as a parent when I go to childcare and have to convince other parents not to give antibiotics to their children. And it's really because they don't know for sure what infection their kid has. They know it's probably viral, as you brought up very wisely. And so I was struck by this competition. I think is really important on rapid diagnostics for antimicrobial infections, but I wondered if you could comment about just having rapid diagnostics so that people know they have this common viral infection, and so therefore don't go down that slippery slope of a bunch of antibiotics.
Well, that was exactly the problem that made me ask for this in the Longitude Prize. It is very difficult, isn't it? And I hope someone will come up with the right diagnostic. The other way of getting at it must be that there are a limited number of viruses that cause viral sore throats, and maybe you could get at it by diagnosing one of those rather than something else. I don't know. The other thing that's been done very successfully, a nice randomized controlled trial in Britain, was delayed prescriptions. So the doctor saying to the mum, I think this is viral, but here's a prescription, don't cash it in for 24 hours, and if after 24 hours your child hasn't made an improvement, you could cash it in. And it's, when used well, that reduces antibiotic use. But I have the same problems.